All right, it's 6 o'clock, which means I can officially welcome you all to our session. Let's see here. So yeah, welcome to the Health Equity Grand Rounds Echo. This is the fourth of our 6-part series exploring racism in medicine, health equity, and COVID-19 in Alaska. This echo is jointly provided by the Alaska Black Caucus and UAA Center for Human Development ECHO project, with support from grant funds awarded by the Municipality of Anchorage, Anchorage Health Department. My name is Erin, my pronouns are they, them, and I'm an ECHO coordinator with the Center for Human Development's ECHO project. I'd like to go ahead and invite, let's see, Deanne, do we have Deanne with us? I don't think so. Ms. Celeste, are you available?
Hi, I am actually out of state, but I do want to thank everyone for being here today. We are working with the University of Alaska ECHO team in partnership to bring forth the ECHO series. We recognize that we've got a lot of work to do as it relates to equity and healthcare. And so we, again, appreciate you being here, and I'm looking forward to this conversation. Thank you.
Thank you so much, Celeste. So yeah, I appreciate that introduction to the vision that's driving this initiative and the purpose of our ECHO, which is informed by the efforts of the Alaska Black Caucus. Again, so thank you to the ABC team for joining us and participating and providing that introduction. All right, participants, whether you've joined in on ECHOs before or if it's your first time, it's important to know that engagement with the group is integral to the all teach, all learn philosophy, which underpins our program. We encourage everyone to ask questions and make comments during our session by utilizing the chat box, or when appropriate, by unmuting yourself and sharing directly with the group. You're also welcome to private chat myself, the session host, or any member of our hub team if you'd like your questions shared anonymously during our session. We are also happy to offer CME, AMA PRA Category I, and Nursing ANCC credits for our series. In order to claim these credits, you must attend our live session and complete an evaluation that's linked in the chat box at the end of our session. Once you've completed that assessment, you'll be redirected to a JOT form where you can fill out and download your certificate of completion. This evening's session is on healthcare access experiences of Black, Indigenous, and people of color, featuring a didactic presentation by Professor Dorothy Roberts, award-winning author and expert on the interplay of gender, race, and class and legal issues concerning reproduction, bioethics, and child welfare. We'll also have a case presentation by Dr. Rachel Burvell, co-founder of the Black OBGYN Project and a medical resident at Johns Hopkins Hospital. All right, a few Zoom reminders before we get started. If your internet connection does not support audio, you can find a phone number to call in the chat box along with the meeting ID. Closed captions are automatically generated during our session and can be enabled by selecting the CC icon at the bottom of your Zoom screen. We also invite you to take a moment to turn on your camera so that we can all get to know each other if that suits you and you're available. You can go ahead and do this by selecting the camera icon on the lower left of your Zoom screen. Again, we do ask that you keep your microphone muted during our presentations and when not speaking, and you can mute and unmute yourself by selecting the microphone icon on the lower left of the screen or by pressing *6 if you're calling in via phone. And to help further build connections and foster participation throughout our ECHO, we like to start each session with introductions. So Hub team, as I call on you, if you wouldn't mind introducing yourselves with your name and pronoun, your role in organization, and what drives your passion for health equity. And participants, we also invite you to share the same of yourselves in the chat box and let us know as well what you hope to receive from this ECHO. And we appreciate the opportunity to get to know you just a little bit better in that regard. All right, let's see. Dr. Mendoza, if you wouldn't mind kicking us off with introductions, please.
Yes, good evening, everyone. I'm a local family physician here in Anchorage, Alaska, and also a hub team member. And I'm also passionate about health equity and being an agent of change, trying to use healthcare, direct health services as a family doctor to break the cycle of sickness and poverty in our community. So, thank you for having me.
Thank you so much, Dr. Mendoza. And Dr. Mandat.
Hello, everyone. My name is Maddie Mandat. My pronouns are she, her. I'm a hub team member. I'm also an integrated pharmacist at South Central Foundation here on Denina land in Anchorage, Alaska. What drives my passion is I love working with teams. I'm here in allyship and in solidarity with the BIPOC community. I'm a Filipino-American queer woman. Just want to recognize our intersectional identities and happy to be here, happy to learn.
Thank you so much. And Panna.
Good evening. My name is Panna Lynch-Jerusi. My pronouns are she, her. My role in this process is as an Alaska Black Caucus Hub team member supporting the Health Equity Grand Rounds ECHO, and I'm here to grow and to learn. I'm a nationally board certified school nurse with the Anchorage School District, having served 5 years at Fairview Elementary and finishing my 20th year at Robert Service High School. I'm beginning my doctorate journey in nursing at Purdue University, and my passion of operationalizing health equity for BIPOC and marginalized populations in Anchorage has fueled my passion for this journey and my progressive efforts with the Alaska Black Caucus. Thank you for your time.
Thank you so much, Panna. It's always a pleasure to have you join us. Ken.
Hi, good evening. My name is Ken McCoy, and it's an honor to be here with you tonight. My pronouns are he, him. I'm a recently retired police chief here in Anchorage, Alaska, and I now serve as the Chief Diversity, Equity, and Inclusion Officer for Providence, Alaska. I'm hoping that through these conversations, we can identify barriers and find solutions to bring true health equity to our community. So again, thank you for having me. Honored to be here.
Thanks, Ken. And Dr. Alou.
Hey, good evening, everyone. My name is Obi Alou, currently a pharmacist transitioning into a legal career. Currently, what drives my passion for the hub sessions that we're having is that I've had the opportunity to experience both perspectives, being in healthcare and also receiving healthcare as a minority. And I understand the importance that this dialogue on race and healthcare disparities, the importance of it and the mission that the Alaska Black Caucus is doing. And I'm happy and proud to be a part of that. Thank you.
Thank you so much, Dr. Alou. All right, and thank you to those folks who were able to introduce themselves in the chat. I really appreciate it. All right, a few final reminders before we get started. The opinions of our hub team and presenters are their own and do not necessarily represent those of the Alaska Black Caucus, UAA, the Municipality of Anchorage, Anchorage Health Department, or any ECHO sponsors. Additionally, Project ECHO, you know what, I'm so sorry. I clearly skipped Dr. Tracy Weiss. So Tracy, I'm so sorry. Would you mind introducing yourself?
It's okay, no problem. My name is Dr. Tracy Weiss. I'm a doctorally prepared nurse practitioner, board certified in both family practice and psychiatric mental health. I'm the clinical director at Identity Health Clinic, which is Alaska's only nonprofit health clinic, which focuses on the needs of the LGBTQ2IA+ community. And I am here because we know, especially in queer healthcare, that we can't really do good healthcare for gender and sexuality if we aren't looking at the intersection of our folks within that community who are also people of color. So I'm mostly here to listen and learn and to help take that knowledge and education back to the providers at my clinic and the community at large to look at those intersections between gender, sexuality, and race and ethnicity, and how we're managing everything that we're doing for healthcare. So glad to be a part of it. Thanks, Erin.
Thank you so much. And sorry for that oversight. Sometimes the Zoom format isn't really conducive to getting everybody. All right. So again, just back to these reminders, Project ECHO is not HIPAA compliant. So we do ask that no protected health information is shared or displayed at any time. And finally, I also want to acknowledge that the subjects that we're discussing carry weight. And as we will explore during this series, racism and its impacts are not abstractions. They exist materially, bodily, emotionally, and spiritually. And I invite those joining in on today's discussion to do so with that in consideration, to listen, to keep questions and comments on topic, to be considerate, and to use language that is respectful, especially when in response to those with lived experience and expertise. So again, thank you to everybody in advance for following those guidelines. And with that, folks, I'm so pleased to turn our session over to Professor Roberts to share her presentation with us. Professor Roberts.
Thanks so much, Erin, and thanks to everybody here today sharing in a discussion about racism in medicine. So let me share my screen. Let me put this back here. Okay, does that look good?
It's great.
All right. So I decided to call this Ending the Legacy in Racism in Medicine because a large part of my talk will be about the history, the long history of the relationship between race, racism, and medicine. I think in order to understand the depth of the problem today, we need to look at its origins. And there's so much I could say about this topic, but I decided to focus on two aspects of it. One is the way in which the very meaning of race and the myth that race is a biological, natural division of human beings has fueled this long legacy of racism in medicine. And the other is to connect this topic with a topic I've been working on a lot, which is the child welfare system and medicine's relationship to it. What you'll see I call the family policing system. And so those are two central aspects of my talk today. And of course, I'm happy to talk about other aspects as we move into discussion. So I know that one of the issues that this group is working on is racial disparities in the impact of the COVID pandemic. And so you're probably aware that very early on in the pandemic, all the way back in 2020, it became very obvious that there were huge racial gaps in deaths, both infections and deaths from COVID, with Black Americans dying from it at far higher rates than others, especially than white people in America. Also, Indigenous, American Indian, or Alaska Native, as the category is called, people and Latinos or Latinx people also dying at higher rates. Now, the first question that comes to mind, of course, is why? Why is this? And there have been lots of hypotheses circulated, but I want to point out that immediately there were articles published in peer-reviewed journals speculating that there was some innate reason why Black people were dying at higher rates. In other words, something inside Black people's bodies that made us more prone to getting the disease and dying from it. So for example, reference to some unknown or unmeasured genetic or biological factors. Again, the possibility that genetic or other biological factors predispose Black people to more severe disease, and even some articles pointing to possible genetic differences between Black people and everyone else that might explain why we were more susceptible to the disease and to death from it. And I say dueling hypotheses because there's also a very different explanation. And we might look to this interview with Kamara Jones, a former president of the American Health Association, who's been a American Public Health Association, who's been a great advocate for ending health inequities and explaining how structural racism and social determinants are the reason for racial inequities. And so she said, which I think is a really helpful way of thinking about health inequities, that it's racism, not race, that's a risk factor for dying of COVID-19. And she pointed out that Black Americans are more likely to get the virus because of structural factors like lower income, the higher likelihood of living in concentrated poverty, segregated neighborhoods that are predominantly impoverished, having to work in jobs that expose you to COVID, and getting to those jobs on public transportation, where you're more likely to be infected. And then once infected, again, these structural reasons why Black people would be more likely to die from COVID, structural reasons that put Black Americans at higher risk of death generally, like being exposed to environmental toxins. Again, some of the same reasons for exposure to COVID are reasons for the higher likelihood of dying from it. Lack of high quality nutrition, and other reasons related to poverty, but especially concentrated poverty, exposure to violence, including state violence, and other risks to health that are more prevalent in Black neighborhoods. And so instead of looking for a genetic reason why Black people as a supposedly biological race would be more prone to dying, it is racism, not race. That's the risk factor. So despite that much more plausible idea that it is the structural impediments to good health that are the reason for these racial gaps in infection and deaths from COVID. And by the way, I left out another important factor, which is lack of access to high quality healthcare. But I think it's important to note that the major factors come far before you get to the hospital with COVID. And the main reasons why Black people are more likely to die have to do with lifelong barriers to health that go far beyond lack of access to healthcare. It's also the exposure to environmental factors that are caused by structural inequality that make Black people more susceptible to death because they're already in poorer health when they get infected, before they get to the hospital. That doesn't mean, though, I don't want to leave out evidence that Black Americans are also treated less well at the hospital, including a report by ProPublica that in New Orleans, there were relatives of Black patients who died from COVID who claimed that their loved ones were sent home without adequate treatment. And that might sound a little bit exaggerated, except that there's lots of evidence that Black people get poor quality healthcare in hospitals, including, for example, it taking longer for them to get treatment for a heart attack when they arrive at the emergency room. And many of you may have heard of stories of Black women who got inadequate care after giving birth. I think Serena Williams brought that to the public attention, but it's a major issue that we're now more aware of now that statistics that Black women are 2 to 3 times more likely to die from pregnancy-related causes, including because of inadequate attention during labor and birth. But let me get to my point about where do these ideas come from, despite all this evidence of the social determinants of health. Why is this persisting, this idea that there's something innate in Black people's bodies and also in the bodies of Native people, and some theories about this for Latinx people as well, something inside, innate, that predisposes people of color to poorer health, but especially Black people. There are more stereotypes about Black people's poor health and more studies about it. There's a particular obsession, I think, in biomedical research and in dominant American culture about the innate negative attributes of Black people, including predisposition to poor health. So that's what I want to talk about. And I think it goes all the way back to what I call the scientific invention of race. And that is that race became a categorization of human beings around the 16th century. Prior to that, there wasn't a concept of human beings all divided into a handful of natural groupings that were so distinct from each other, they could be deemed separate races. In fact, some of the theories back then were that there were separate species of human beings. And we can trace this idea back to the slavery era, the beginning of European conquest of other people and the enslavement of Black people, and the need for the church, the Christian church, to come up with an excuse for Christians enslaving other human beings, especially after those human beings who were captured were converted to Christianity. And so we see the development of a theological concept that God divided human beings into separate races. And Black people were cursed. And there was myths about Noah and the legend of Ham and how God had cursed Black people, and that's why Black people could be enslaved. Now, this idea that God divided human beings into separate races was then transported into Enlightenment science. And even though the Enlightenment era was supposed to be a clean break from theological thinking based on evidence, not on beliefs, it was supposed to be based also on principles of equality and liberty and tolerance, scientific proofs. Despite all of those changes in the Enlightenment era, they took the idea that some natural force divided human beings into races and just transported it into scientific thinking. So now we had European scientists claiming that they could demonstrate that the division of human beings into races was natural. And so that's why I say it was an invention of science, and it was also the race also, this racial thinking helped to create Western science. And so the very origins of Western science are deeply entangled with this myth of race. And it was entirely to justify conquering non-European people and even exterminating them and enslaving them. Now, that idea was promoted by physicians, and they developed during the slavery era the racial concept of disease. And that's the idea that people of different races have different diseases and experience common diseases differently. It was a way of both seeming to prove the biological concept of race, but also a way to justify enslaving African people. And it is an idea that continues to dominate medicine today. Most medical students are still taught the racial concept of disease, that people of different races have different diseases and experience common diseases differently. Most medical students are taught to identify the race of the patient and to treat the patient according to their race. This is simply a false idea that, again, we can trace back to folklore, but it has continued to dominate because it's a very useful idea, useful in the sense that it always has had, which is it helps to justify racial inequities that are actually caused by unjust structural racism. But to give you just one example of a very important doctor who promoted this idea, Dr. Samuel Cartwright, who trained at my university, University of Pennsylvania, the first medical school in the nation, in the colonies at the time. And Penn trained most of the elite Southern doctors. Penn had more doctors, I should say medical students from Virginia than from Pennsylvania. And one of those doctors was Samuel Cartwright, who after training at Penn went back to the South. He actually got his medical degree from the South, and he was commissioned to write a report on the diseases and peculiarities of the Negro race. And he claimed to discover all sorts of diseases that only Black people had, one of which was drapetomania, or the disease that caused Negroes to run away. He claimed that Black people who fled plantations had a mental disorder. But his main theory was that Black people had lower lung capacity and therefore had to be forced to work by white people in order to be healthy. And we can trace his ideas about lower lung capacity to common ideas in medicine today, that Black people have lower lung capacity than other human beings. Now, many of us thought that when the Human Genome Project was mapped and it was declared by the key scientists and Bill Clinton and Tony Blair as well, that race could not be found at the genetic level. As Clinton said, in genetic terms, all human beings, regardless of race, are more than 99.9% the same. And probably even more important is that although there's a lot of genetic variation among human beings, it isn't divided into races. It's long been known that there's more genetic variation within populations that are called races than between them, and that Africa, for example, has more genetic variation than the rest of the world combined. So it makes no sense to say in genetic terms, for example, that there's a Black race or an African race. But despite that, soon after, it was predicted that on the front page of the New York Times, that the next phase of the Human Genome Project would be to explore the genetic differences between human races. And in fact, there was an increase in scientific studies looking for genetic differences between races and trying to explain inequities, especially inequities in health in terms of genetic difference. After being very alarmed by this, I wrote a book called Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century, where I showed that scientists, despite all the evidence, were defining race as a genetic grouping. Some of them, not all of them. There are many who have opposed this trend, but an alarming number of scientists who continue to define race as a genetic grouping, and that these ideas were being used as explanations for racial inequities. Again, especially racial inequities in health. In other words, instead of focusing on the structural reasons for health inequities, there have been more and more studies trying to find some explanation in innate genetic differences between races, and also developing pharmaceutical and other kinds of biotechnological products to remedy these inequities instead of the structural changes that we need in order to end racial health inequities. Now, these ideas are so embedded in medicine today that there are a number of diagnostic tools that automatically correct for race, that automatically adjust the measure depending on the patient's race. And here's one example of a very common race adjustment for the estimate for glomerular filtration rate, which is a really important indicator of kidney function. And you see here that if the patient is non-African American, the number is 86, which is less normal. But if the patient is African American, it's adjusted upward to 89, which is a more normal number. In other words, with the same amount, this measures an amount of a protein in the blood. I won't get into the details of it, but the point is the same amount is seen as healthier if it's in an African American patient. And I'll get to what the implications of this are, but you can just logically see that the African American patient is less likely to be referred to get specialized care because they're seen to be healthier. And this is based on the assumption that Black people as a group have something about their bodies that's so different from all other human beings that there can be this automatic adjustment in this diagnostic tool. And it's not just EGFR. A recent article in the New England Journal of Medicine listed numerous automatic adjustments in algorithms like the EGFR in cardiology, in not only nephrology or kidneys, but also obstetrics, in urology, neurology. Just about every aspect of medicine has these automatic adjustments based on race. And as I'll get to, they're being shown now that people are finally paying attention to this and criticizing it, being shown to be very harmful to Black patients. In an article I wrote in last year in Lancet, where I called to abolish race correction, I pointed out 3 problems with it. One is that it shows a failure to understand the meaning of race and its connection to racism. It ignores that race is not a biological category. It's clearly a social category. Obviously, you cannot treat all Black people the same for, whether we're talking about their experiences, whether we're talking about their ancestry. But for whatever reason, you cannot treat Black people as a unified biological group. And it misses that the reason why we have this idea that races are natural divisions of human beings is in order to justify enslaving and conquering and exterminating people, non-European people. And in other words, racism produced these ideas about race. And you cannot, in my opinion, cannot use them. Whether you consider yourself a racist or not, they are racist ideas. It also shows the failure to recognize the harms of this. I mean, I thought it was quite astounding that anyone would want to adjust upward the measure of kidney function when Black people have higher rates of end-stage kidney disease. You'd think you'd want to make very sure that if you have a Black patient, you are not dismissing their risk, the individual's risk of kidney disease, but it does just the opposite. And the fact that it's persisted, despite all the evidence of its harm and its basis in false thinking, shows an unwillingness for some in medicine to change. Another example of the harms of race-based medicine is the undertreatment of Black people's pain. Numerous studies have shown for more than 2 decades that doctors are less likely to give Black people any pain medication for similar injuries that we know are painful compared to white patients, or give them inadequate amounts of pain medication. And a recent study looked at the reason why, which I think is pretty obvious that it's based on false ideas about Black people's bodies. But one study found that a substantial number of white medical students and residents held these false beliefs about biological differences between Black people and white people, like Black people have thicker skin than white people, Black people have less sensitive nerve endings than white people. And they showed that these beliefs predicted this undertreatment of Black people for pain. Another aspect, which gets to my current work on the relationship between medicine and the family policing system or the child welfare system, child protective system, is evidence of physician bias in suspecting, testing for, and reporting child maltreatment. And this has been shown in a number of cases. For example, racial differences in the evaluation of fractures for physical abuse when young children are brought to the hospital. Studies have found that doctors not only are more likely to suspect Black parents for the same injuries to children as white parents, and they're also more likely to miss child abuse in the case of white children because they're less likely to suspect that white parents abuse their children. Also, another area where there's lots of evidence of racial bias is in the testing of Black and Latina mothers for drug use while pregnant. And currently there are 3 New York City hospitals that are being investigated by the Human Rights Commission there for this disproportionate subjecting of mothers of color to drug testing, and then also reporting the results to Child Protective Services. I began looking at this issue when I worked on my book, Killing the Black Body, back in the 1990s, looking into the prosecutions of Black women who are pregnant and using drugs. And that's when I discovered this extremely disproportionate rate of drug testing of Black mothers compared to white mothers, and reporting of their positive toxicologies to police and CPS. And my most current work, which just came out last month, Torn Apart: How the Child Welfare System Destroys Black Families and How Abolition Can Build a Safer World. I call for ending this drug testing, mandatory drug testing and reporting altogether. And in fact, I think that we should end this surveillance of families that does not keep children safe and traumatizes children from family separation. I'm just going to say a little bit about the racial disparities in the child welfare system, which the medical profession contributes to through its biased reporting. There's a huge disparity in the numbers of Native American or Indigenous children and Black children who are taken from their families and put in foster care, with very high numbers. More than 15% of Native children and almost 12% of Black children are going to spend some time in foster care before they reach age 18. Also, CPS investigates a huge number of families, the families of 3.5 million children every year. And the number for Black children is truly astronomical, with this study finding that more than half of Black children will be subjected to a child welfare investigation before they reach age 18. Another finding: high rates of investigation of Black children in large US counties, up to, in one county, almost 63% of Black children subject to investigation. Most of these investigations and family separations are based on neglect, not physical abuse. Very small percentage have to do with physical or sexual abuse. Most of it is because of unmet needs of children related to poverty. And this is based on a long history of the use of family separation to target the most politically marginalized communities in America, going back to the historic separation of Black families during slavery. Also, court-ordered Black child apprenticeships back to former enslavers after the Civil War ended, and a long history of the US government using family separation, child removal as a weapon of war against Native people all the way into the 1970s. Just 2 days ago, Interior Secretary Deb Haaland issued an initial report that more than 500 Native children who've been taken forcibly from their homes and put in US institutions were killed or died, but killed from the conditions between 1819 and 1969. And part of the reason for these high rates of family separation is because of the way in which neglect is defined by state statutes, which basically is a definition of poverty: the failure to provide proper necessary support for a child's well-being. Some list the specific material needs of children that are unmet, like food and clothing and shelter. And in the vast majority of cases, this is because parents can't afford it. And instead of our nation providing what family caregivers need, they are children are taken from their families, and as I mentioned, in extremely racially biased ways, causing trauma, health. This contributes to health inequities as the healthcare system contributes to these racial disparities. And I just want to point out that the higher rates of child removal in Black and Native communities mirrors the higher rates of poverty, childhood poverty in those communities, as well as the fact that the United States has one of the highest rates of childhood poverty in the, well, it has the highest rate in the among Western nations. It also takes more children from their families than any other Western nation. And so this relationship between the healthcare system and family surveillance means that hospitals and other health clinics become places that families fear because they're afraid they'll report them for child neglect if they bring their children to the hospital, instead of the potential for healthcare institutions to be truly supportive hubs for families. There's a growing movement to abolish this system and replace it with an approach that truly supports families and keeps children safe. So let me, I'm gonna move a little faster to conclude. The way in which I explain health inequities is to reject the idea that race is a biological category that naturally produces them, but to understand that race is a political category that does have staggering biological consequences because of the impact of social inequality on people's health. There are more and more studies now that are looking at ways in which structural racism affects people's health, how it gets embodied or under the skin. And there are more challenges to the way in which race has been treated as a biological category, including the National Football League. Black players, former players in the National Football League, who found out that they were getting lower damages or being denied damages in the concussion settlement because they were being tested for dementia on a different test than the white players. The test for Black players assumed that Black players already had lower cognitive capacity as a race. And so they had to prove more damage from playing football than the white players did. And they claimed this was race discrimination, and they were able to get the racially biased test removed so that all the players were tested on the same test. We're also seeing challenges to a number of these race corrections in obstetrics, as well as the EGFR, showing that they harm Black patients. Just to point out one statistic, this recent study found that over the last few years, 31,000 Black patients would have been eligible for a transplant, getting on a kidney transplant waitlist if they weren't being tested according to that race correction and kidney function. In an article that I co-authored with Jonathan Metzl in the AMA Journal of Ethics, we suggest a few ways that the medical profession and everybody in public health can address these issues. One is to stop ignoring racism in medicine, and under the grounds that doctors aren't racist, so they don't have to worry about it, or these kinds of procedures that are race-based, or race-based medicine in general, has some kind of scientific authority. Healthcare should be affirmatively anti-racist. It's important to be interdisciplinary, to learn from the social sciences and humanities, to understand the true meaning of race and how structural racism operates, to be creative and collaborative in addressing structural problems, both inside and outside the clinic, and to speak up and organize around structural issues that impact patients and public health. So my overall message is that the best way to end health inequities and create a healthier society would be to create a more equal society. And we should be moving toward that, and to affirm our shared humanity by working to end the social injustices preserved by the political system of race. So I'll end there, and I'm happy to answer questions, engage in discussion, however you want to proceed.
Excellent. Thank you so much, Professor Roberts, for that comprehensive presentation. Really, thank you. Dr. Alou is going to be facilitating the Q&A portion. So folks, participants, if you have any questions, feel free to enter them into the chat or raise your hand and come off of mute. Over to you, Dr. Alou.
Hey, thanks so much, Erin. And thank you again, Professor Roberts. That was informative and insightful. A lot of things that you brought up that I wasn't aware of or didn't know all the facts surrounding it. So there are a few people who have posted a few comments in the chat. Just want to make sure we highlight a few of them. So it looks like, so McKinley Rouse stated that being African-American, they've ran into where they've gone and to see their family practice provider and being told that their numbers are good or bad based off of their race. So kind of what we've discussed this evening. So McKinley, I don't know if you have any additional information you'd like to add or expand to your comment.
Not really, other than just to say that I hear it all the time when I go to see my doctor. Well, because you're an African-American,
Yeah.
this number is good, or it's good
Right.
for African-American, or
Yes.
African-Americans don't need to be as concerned with this particular number, you know, because I get routine tests done, and I'm continually told that I'll be given a number. This is your number for this, but it's good for African Americans.
Right. Yes. Yes. That's what is so, I don't know, ironic about it. I mean, it's so disturbing that so many of these tests assume that Black people's bodies function more poorly. And so if you have a test that shows that your body is functioning more poorly than the average person of another race, it's seen as normal for you. And so you're less likely to get the follow-up. I mean, that as I pointed out with the EGFR, it's an upward adjustment. And so it looks like your kidneys are healthier than if someone of any other race, you know, any other human being had the exact same indicator. And this is, I'll give you another example. I went through the slide quickly where I was showing that the studies are now showing harms. There was a study about anemia in pregnancy, and it is assumed, this test, that Black women naturally have lower iron levels. And so the guidance for when to treat anemia during pregnancy is less likely to be concerned about Black pregnant women who have low iron levels. Well, it almost seems obvious. Do you need a study to figure out that then Black women are going to have poorer outcomes because they haven't been treated for anemia? And sure enough, a study that was conducted by some researchers at Penn found this out. This is bad for Black women. They are more likely to have harms to them from anemia during pregnancy. There are other times where it works the opposite. For example, with the VBAC calculator, vaginal birth after C-section, the test made it less likely to advise Black women to be able to have a vaginal birth after C-section. Now, that may seem as if, well, that means you're more concerned then about Black women's ability to have a vaginal birth after C-section, but the impact is that to increase the number of C-sections that Black women have, which also carry risks, and we have a very high rate of cesarean section in the United States. So one after the next, they're finding that there are negative impacts on Black patients because of these corrections. And I think, just like the NFL said, this is race discrimination. Why isn't it race discrimination in all of these other same kinds of corrections as well? So I think we're going to see more of that, because these studies are coming out more and more and more showing, documenting these harms.
Yeah, thank you so much, Professor Roberts. Definitely a lot of great information there. And I just want to highlight something else that McKinley pointed out regarding something that you mentioned as far as white patients being more likely to be treated with pain medications or higher amounts of pain medications, and maybe how that's also contributed to the explosion of opioid epidemic, and how it's impacted the white community or white population as well.
Yes, I think that's a very good point. And there have been studies looking at this. Helena Hansen, who is a physician anthropologist at UCLA, has written about this. The whole opioid painkiller surge that happened was based on a particular kind of marketing for white patients. The marketing of it was that this was a drug for white patients and that there wasn't a problem with it, in part because of the stereotype that white people are immune from drug addiction, but Black people are susceptible to it. And in fact, there's a study that showed that even for Black children presenting at the emergency room in severe pain from appendicitis, white children were 3 times as likely to be treated with opioid medication than Black children. So that shows both, and why I think that is based on a stereotype that the Black children will become addicted to it, in addition to they don't feel pain as much, even though these are little children screaming in pain from a cause that we know is painful, appendicitis. So I think it's a combination of thinking that, I don't know, that little children, Black children don't feel pain as much, but also this idea that they may become addicted, whereas white children and adults won't. And yes, this has been tied to the overprescription of opioids to white patients and why the opioid epidemic began in white communities. Now, it has spread to Black communities as well. But again, note the stereotypes. If there were a drug addiction that started in the Black community and spread to the white community, they'd say, oh, Black people are spreading disease, to white people. But you don't hear anything about the opioid epidemic being pushed into Black communities from white addiction. And another thing about it, I have never once ever, and I've studied this, never once read a study that hypothesized that white people were genetically predisposed to addiction from opioids. It has always been a social explanation. The distress that white people feel because they don't have the privileges that they thought they were entitled to. That's the main explanation I've heard, that because of creeping income loss in white communities, there is a depression. And this is, I mean, I could go on and on about this. I don't want to take up too much more time, but we know that the only group in America whose mortality rate is going up, even though it's lower than Black people's, but it's going up, is white Americans, especially less educated, lower income white Americans. And it's mostly from drug overdoses and suicide by guns. And here I highly, and the explanation for that, though, no one has put out hypotheses like I showed you at the beginning about COVID, about some unknown genetic cause. No one ever says that. It's a social understanding of why there is addiction in white communities or why there's suicide in white communities. There's nothing about some innate predisposition to death that you find still as to Black people. And so, these racial stereotypes and biases, in addition to structural racism, are so prominent in biomedical research and medicine to this day.
Thanks so much, Professor Roberts. So for the sake of time, just because there's so many great questions and comments that are being typed into the chat, I just want to highlight a few other ones real quickly before we do have to transition to our case.
I know.
So Samantha, and this is maybe something hopefully that you might be able to provide us, and we can also share with the folks that were able to join us tonight, but she was also wondering if there were any books that you could recommend that give specific examples to some of the racist medical practices. And I'm sure you've probably got a wealth of literature that you're able to share. So
yeah, so I did, Aaron, I gave some sources to Aaron. Also, I'll just mention two more. One is Lundy Braun, Breathing Race into the Machine. And Professor Braun traces the modern day spirometer, which measures lung capacity and which still sometimes is used with a race correction to correct for the assumed lower lung capacity of Black people. And she traces that back to Samuel Cartwright's ideas during the slavery era. And another, this is just based on my comments now, but I have other sources that I sent to Aaron, which he can share. But based on that last question, I would recommend Jonathan Metzl's book, Dying from Whiteness, where he points out how these racist ideas and the investment in whiteness has harmed white people, especially white people's health. And he points to the opioid epidemic, the lack of support for Medicaid among many white people. He quotes a man he interviewed at the beginning. He says, "I would rather die." This man has health problems, white man. "I'd rather die than give Medicaid to Black people and immigrants." So he points out that these policies are harming white people who don't have adequate health care. And the other is guns, that there's a lot of promotion of guns among some white people based on the idea that they have to protect themselves from Black people. And he points out that most of the deaths of white people are from guns, are them killing themselves. And he points out the higher rates of suicide by guns in states where there is this big push for more guns, and even the report that just came out, of course, shows very tragically, we have to deal with this as well, that young Black men are 20 times more likely to die from gunshots than young white men, but most deaths from guns in the United States are suicide deaths. So most white people very few are dying from Black people with guns.
Mhm.
They're dying mostly killing themselves or killing their family members. And so what Metzel's trying to point out is that white people who oppose healthcare policies and policies to reduce gun violence based on racial stereotypes or on their own investment in whiteness are actually hurting themselves. And, I think structural racism hurts people of color, Black, Indigenous, and people of color the most, but it also hurts white people as well.
Oh.
And, that's an important lesson to learn. As I said at the end, and we could close with my part with this, the end of my talk, the best way to have a healthy society for everyone is to have a more equal society. A society without structural racism would benefit everyone's health, including white people's health.
Yeah, thanks so much, Professor Roberts. So there are a few other questions that unfortunately we may not be able to get to unless if there's additional time at the end. But in light of our case presenter, I want to go ahead and pass it over to Erin so that we can move on and transition to our next portion.
Excellent. Thanks so much, Obi. And thanks, again, Professor Roberts, for engaging with our participants on some of those questions. So we're now moving into the case presentation portion of our session. For those that might be unfamiliar, case presentations are an integral tool which Project ECHO uses to affirm the all teach, all learn philosophy. And the aim for our case presentation today is to invite our participants to share their expertise, lived and learned, and to create a forum where complex issues can be examined with nuance and care. Just a reminder that ECHO cases are de-identified and no protected health information is to be shared at any time. And after our presenter, Dr. Burvell, shares their case, our hub team facilitator, Dr. Alou, will ask participants for any clarifying questions to gather additional information, and then we'll move into the portion of our session where we can take suggestions, recommendations, comments, and questions. All right, so as mentioned, today's presentation is by Dr. Rachel Burvell. And Dr. Burvell, I know we're running a little bit short on time, so I'll go ahead and invite you to share just briefly a little bit about yourself, and then we can move directly into your presentation.
Absolutely. Hi, good evening, everybody in Alaska. I am calling in from the lovely East Coast. So it was nice to see the sun on your faces while we're here in darkness. I am currently a medical resident and trainee, started my training at OBGYN and continuing in preventive medicine at Johns Hopkins. And I'm also the co-establisher of an Instagram page called the Black OBGYN Project, which I established in 2019 and has since become a space to discuss, really, as Dr. and Professor Roberts, who I am such a big fan of, mentioned disparities in medicine as they relate to our health and our well-being, specifically with the lens on maternal health. So I'm going to start and get right into my presentation because I do actually go through a couple cases, and I want to make sure that we leave a lot of space for questions at the end. Oops, that's not the right button. Sorry. Questions at the end, as well as an opportunity for you all to share in the chat. I think it's really important when we have these discussions about health disparities that we remind ourselves we're in a safe space. And so I love that this case part of your presentation for ECHO gives people the chance to kind of find what's deep inside themselves. If there was an answer to why there was racial disparities in medicine, or at least the solution, myself and Professor Roberts wouldn't be here tonight discussing this over and over again. And so there are no wrong answers. And so I urge you to please use the chat to respond. I'll be asking a lot of rhetorical questions for mostly the sake of time, but use the chat in order to be a bouncing board of ideas and feelings in this situation. As with all presentations, I have no disclosures. I already mentioned that I started the Black OBGYN project on Instagram. Encourage you to discuss with me while there if you have a social media page. But I'm going to jump right in. I'm going to start with a story of a Black woman. Her name is LaShonda Hazard. And in 2019, she walked into the hospital complaining of horribly severe abdominal pain. She was otherwise, to our knowledge, a healthy 27-year-old in the second trimester of her pregnancy. And even though she complained of pain and it being excruciating, the hospital really did nothing more than check the baby and send her home. Probably check fetal heart tones and say, hey, sorry, nothing we can do. Just shortly after, she took to Facebook and she wrote, I've been having excruciating stomach pain, cramps, and there, the hospital, not doing anything about it. My whole left stomach is hard and I'm in pain. When some friends continued to ask what was going on and tried to understand in the comments how she was feeling, she responded that she was feeling worse. She noted that the hospital said that there was nothing that could be done and that she was literally dying. The thing is, Hazard was literally dying, and she died a couple hours later. Her untimely death occurred in 2019, and in the last 2 years, we have seen this narrative replay itself in various forms again and again and again. I think that we have to keep in mind that when we hear these stories, like Dr. Shanice Wallace, who was a medical resident actually in Indiana, or we hear of Amber Rose Isaac, who was a young woman who actually during COVID actually was begging to be seen in person and was not, or we hear of Nicole Thea, who was a YouTube icon, and I believe she was a fashionista, had a great following, or the heartening story of Shaisha Washington, who also died during COVID. We think and we try to understand what is going on, what is causing these young women, otherwise healthy for the most part, from what we understand, to have an unfortunate death. What are we to make of these unfortunate deaths in the first place, right? It's really not debatable that Black and Indigenous people in this country, in the United States, die in the perinatal, meaning before pregnancy, during pregnancy, and postpartum, at a rate, and Professor Roberts actually just mentioned it, 2 to 3 times more than white people. And for some studies, that has gone up to 3 to 4, at least according to the CDC on their website. And this also includes Indigenous people, birthing people as well. And so when we see that there's this gap, we have to think, is it racism that's playing a role in these deaths? There's a difference when we look along racial lines, right? But then we have to go to the next question. What evidence do we have, if at all? Oops, if my slide decides to work, oopsies. What evidence do we have at all to say that it was racism that caused these women to die, right? I'm going to be devil's advocate for a minute. Who's to say that it wasn't just an incompetent hospital, that when Miss Hazard went there, they just brushed her pain off as maybe some Braxton Hicks or some regular cramping? Or who's to say that these aren't just a couple bad actors that are being racist, right? So when we say bad actors or bad apples, I'm talking about that one doctor who came forward and said, hey, I don't like this person because she's Black, and so I'm not going to admit her, or I'm not going to do further investigation, so I'm going to send her home. The thing is, within medicine, these conversations are become really nuanced, which is the interesting part and actually the sad part of all of this. When we think about racism in medicine. When we think about and reflect on hazardous death, along with so many others, what can be understood is that there is some sort of manifestation of racism that's showing itself so much in the field of healthcare. And as such, what I'm going to do for the next, hopefully 20, 15 minutes or so, we really need to examine our related biases in order to understand why there are continued disparities along racial lines in maternal health, in COVID-19, in so many other facets of medicine. And so I'm going to walk through a couple scenarios that I've put together to help us illustrate how intertwined and complicated it actually is to pin a single origin for racial disparities in medicine, but how essential it is to ask ourselves these hard questions that in many ways we still don't have the answer to. So first, and feel free to pop it in the chat if you think you know, what is the basis for our medical biases? I'm a physician, right? Why is it that when I see Miss Hazard, or when I would have seen her, I would have sent her home, and unfortunately she would have died later that evening? Well, you see, the basis of medical biases are so much more layered than what any of us can imagine. And Professor Roberts did a great job of discussing a little bit of the mindset some of us have. Is it in genetics? Maybe these disparities are particularly salient because there's some biological proof. Well, let me describe a little bit more. Early medicine relied on identifying perceived inherent differences between people and often races, as was discussed just about an hour ago. And while I'm not going to remark on the whole history of race in science and medicine in this particular gathering, I do want to say and make sure that you walk away learning and understanding that the conceptualization of race as biology has been rooted in our culture as early as colonialization, and it's leading directly to our understanding of disparities, right? Race began in our society as a function of identity delineation, where you had scientific racism that emerged from ideas and theories of biological inferiority. That included, we talked about Cartwright a while ago, but Carl Linnaeus's polygenism. If you kind of look at this illustration, which I find very cute, of different skull sizes, which was proposed by Dr. Samuel Morton, where he said that white colonizers had different brain capacity compared to Native people, compared to enslaved Blacks. But these are flawed theories. Unfortunately, they've become cemented social conceptions, even up to today, that for whatever reason, skin tone and race classifications have been associated with some sort of difference with between white and non-whites. There's a biological basis. But though this was not based on, this was discussions from the past, and this was not based on any like proved evidence, today there's a little bit more complicated factors, right? Because now people are starting, as Dr. and Professor Roberts talked about, connecting that to genetics and DNA. I just want to say again, as you've heard, doctors, academics, scholars, we wholly reject the notion that racial disparities in healthcare are the result of genetics. So please don't walk away being like, oh, is the basis of bias based on genetics? No, what I'm trying to say is this archaic concept has continued to influence the way we as providers think, quite literally think about our patients. And I was going to ask a question here, like how many of you have seen a study offering to explain racial disparities in health and genetic terms? And I hope all of you, if you were paying attention for the past hour, raise your hand, because now we all know that these studies, even up till today, continue to be purported over and over and over again. And it's funny because I actually quoted Dr. Roberts, again, huge fan, as she has stated in her writings, it's implausible that one race of people evolved to have genetic predispositions to disease, right? There really is no evolutionary theory that can explain why African ancestry, people from African ancestry might be more genetically prone to every disease. It doesn't make sense. We should really reject the focus of genes because it's dangerous and it's a distraction to the actual mechanisms that are underlying why people of color are actually making us sicker. In other words, what I'm trying to say with what the basis of our medical bias is, blaming genes and genetics for our health disparities is an excuse. And so that's out, right? So, okay, well, if it's not genetic, if the basis is not really truly there, is it in individuals? I mentioned that the way I think as a provider is changing. Well, more recently, there has been a focus on provider bias as a potential source of medical disparities. And I was thinking maybe someone would say that in the chat, but I'm not opening the chat at the moment. But currently, we know that everybody here, we all have biases as providers, as nurses, as teachers, that we unintentionally might project to others. In healthcare settings, we might unintentionally project those to our patients and patients of color. I love reading a lot of these books, and Dr. Dana Bowen Matthew wrote, I believe about 6-7 years ago now, Just Medicine, A Cure for Racial Inequality in American Healthcare. And she explored the unconscious bias that's held by healthcare providers that might explain health disparities. And this is what she and what many of us now come to know as implicit biases that make us have unintentional and harmful judgments. Please raise your hand if you've heard of implicit biases or the IAT test, which I have illustrated on this slide, where you can associate a face with either a positive or a negative feeling or emotion. The thing is that, unfortunately, the biases that you might have, again, consciously held or unconsciously held, can directly relate to the inferior care that might be given to a patient. And as a result, that can account for racial disparities. But when I say that, I don't want us to be like, okay, great, we found the reason why there's medical bias is because all those doctors and all those icky little thoughts that they have are making, when Miss Hazard comes in, they're making her not get the care that she deserves. No, I really challenge you. I beg you to not end the search for the basis of bias there. Because yes, providers have implicit bias, but that's an incomplete reason for the numerous disparities that we have in the healthcare system, right? We have to frame our individual biases and thoughts, as painful as it is to admit that some of us might have these thoughts or might not even be able to access them, as the IAT shows, and put them in conversation with the structural and systemic racism that exists in our society. Because if we focus only on implicit bias, we lose sight of the broader picture. And we don't figure out how are we going to alleviate inequality when it comes to not just maternal health, COVID-19, but all the other health issues that continue to have racial disparities, right? And so what can we add to say, individuals, okay, the practice of medicine. And I'm going to give you a true clinical example to frame the source of bias from the perspective as myself as a trainee and a provider, because the way I've been thinking about this, and when I was putting these case slides together, I was like, well, we have the past history, right? It's like you build a house, you have the blueprint from way back when, that was the myth of genetic differences. You have the missteps that we are currently making as infallible humans, but that house that you're building, that, with you inside of it as the infallible human, is in a system that unfortunately is also flawed, right? And so I'm going to read this case real quickly. It's about lung function, which we heard a little bit about in spirometry. Judy's a patient. She's at her local hospital. She comes in for a checkup with her doctor regarding some difficulty breathing. And over the past days, she is hoping that she can get some relief there with her doctor during her visit. And when the doctor looks at the chart, they see that she's female. She's 50, difficulty breathing, shortness of breath. English is her language. She's a Black African-American. She's a smoker. So of course, we're going to do a spirometer test. And I didn't put an image in this presentation, but a spirometer is where essentially a way of identifying the vital lung capacity that an individual can blow out in one sitting or one session. And with that measurement, you can see if there's any deficits or any pathology that's causing that individual to, or disease causing that individual to not reach the maximum vital capacity. So the doctor gets this barometer, but we noticed that the pulmonary lung function test for her did not result in a clinical diagnosis. Judy's doctor tells her that they'll have to do a number of follow-up visits and some additional lab tests in order to confirm her diagnosis. And so not only that day is she in the hospital, but she has to come back for a follow-up and do more tests. She's still short of breath. She departs from the doctor's appointment disappointed. She's nervous. Breathing continues to be labored, difficult. It takes several more appointments to figure out what's going on. Eventually, she's lost a follow-up. She makes these appointments and then she misses other appointments and she has other obligations. There's a hectic work schedule. Oops. And I ask, what is your reaction in hearing this scenario, right? We know that this medical system, we're built to try to help our patients. My goal as a doctor is to support my patients. I love my patients. I love being a doctor. I love helping you feel well so you can get back to serving other people. But when we have a system that already disadvantages certain populations, we're doing them a disservice. And then that burden is complicated and compounded when there's societal issues at the same time that are impacting those very patients. In Judy's case, unfortunately, she had a test that already said that her lower lung capacity was within the range of normal, right? With that spirometer, this race correction factor. And I included this slide that where, I thought it was interesting because I think these are the conversations we have when we're trainees, especially, and people never mean harm when they say things. But a medical student or, myself as a resident, asked the attending that we're working with, hey, do we think that that might have been a reason why her spirometry results were the way they were? And the attending, in good faith, trying to help. Black people are often overdiagnosed and over-medicated. These correction factors will help with that. Truly believing that what we're doing in medicine is for the best of our patients. But then we look around and see how many times, and Professor Roberts talked about this too, how many times in medicine and healthcare, the system unintentionally is doing disservices to our patients, whether in heart disease, whether with the vaginal birth after cesarean section, which yes, might have just changed last year, or GFR, which is about to change if it hasn't already, or now with precision medicine, like I mentioned, these echoes of the past in genes and genetics and DNA, right? Are we doing our patients a disharm through the system itself, through our very own training itself? Not because we are inherently biased, not because there's a really bad, history that we have to kind of hide our face from, but acknowledge that, hey, yeah, that was us back 200, 300 years ago, but the system today. And so there's additional examples. It's the same chart that Professor Roberts shared as well. I highly encourage, and I'll try to share it with Aaron so that they can share it with you all. Highly encourage you just peruse and browse to learn about the equity concerns that are ongoing through medicine and the way that we're trying to hold ourselves accountable to change the way that the system, right? The system is using race as a biological marker for disease and disease states. What I'm really trying to get at with the cases that I've talked about so far, at least, is that there's an interlocking and reciprocal relationship between individual, institutional, structural levels of racism, and it's been embedded in society. It's been embedded in organizations. We know that racism manifests as discrimination, unfortunately, right? Not just in medicine and healthcare, but in criminal justice systems, employment, housing, education, political representation. I thought it was so interesting to hear how that can happen when we are trying to, in some ways care for family structures. But it comes out in so many different ways. And I love the work of so many of the scholars that are trying to highlight the way that this interlocking system of racism plays itself. And I'll try to read this quickly because I know we're at the end of the time. Hopefully I can go like 5 minutes over if that's okay with the ECHO folks.
Yeah, Dr. Gravel, I want to share that we're able to stay an additional 10 to 15 minutes to close out presentation and still address questions. So participants, if you're able to stick around, we invite you to stay for this opportunity to continue the discussion. And with that, again, sorry for the interruption, Dr. Gravel, please continue your case presentation.
This is my last case to kind of hit the lecture, so to speak, and top off the amazing lecture and didactic part as well home for all of you. It's a final example that comes from another one of my academic crushes, Dr. Kiara Bridges, who's over on the West Coast in her book, Reproducing Race, especially for me, someone interested in maternal health and focusing on reproductive well-being. She did an amazing ethnography of pregnancy and its role as a site of racialization. And in the beginning parts of the book, she discusses a case. She did some research, talked to some residents, talked to some trainees, where she looked at Alpha Hospital and Omega Hospital, trainees that rotated at both these institutions. Alpha Hospital is world-renowned, really great, an amazing institution for research and innovation. It's a public hospital. It depends on government dollars. It's underfunded, overstaffed, overburdened, as we all know. Government things happen to be. It sits right next door, at least down the street from Omega Hospital. And that is a hospital that only takes private insurance, no Medicaid. It's a physical manifestation of like all the glitz and glam, right? It's sparkling, it's beautiful. You walk in and you're like, oh, like you can like smell the pianos playing in the lobby. It's like a beautiful place, right? And so she goes to the residents and she just wants to ask about their experiences being at both these institutions. And she talks to a resident, and I know it's a very long quote here, so I'm just going to get to the gist really and summarize. But the resident's like, oh yeah, Omega has way more money, like there's better reimbursement rates. Omega has way better equipment. If someone gets sick, if they need like an MRI, an X-ray, an ultrasound, whatever, like it's on it. We're there, state of the art, high end. We just got the new machines last year. But when we're at Alpha, government funds, we don't turn anybody away because, it's Alpha, of course. It's a great learning opportunity, by the way. But it's the same equipment. It's kind of old, kind of dated. It's really annoying. It's like kind of annoying to be there, whatever. But we try to do our best. We love our patients. But if we're at Omega, if I had to take a call or something, I would never do that. But, sometimes, yeah, I find myself at Alpha taking a call in front of my patient. Sometimes I have to call my patients weeks later if they need those imaging things. And, it's annoying and whatnot. I don't know. I would never do that at Omega, but it's something I do at Alpha. That's basically what this quote says, right? There's this weird attitude thing. There's VIP patients at Omega. There's no VIP patients at Alpha, but I treat them all the same. I love them all the same. What assumptions are being made, right? Assumptions of poor patients not knowing if a trainee is not treating them maybe 100%, or this assumption of this, and what Dr. Bridges writes in her book, of this two-tiered system that unfortunately brings out the worst of people, even if you do not harbor any internalized biases, right? Dr. Bridges writes a lot about this feeling in the environment, a feeling of disadvantage at Alpha Hospital, right? Whether that's because there's armed guards and police law enforcement at the door, or the number of indigent and those who are in need, because again, Alpha does not turn anybody away. maybe those who are homeless, those who are just needing a place to sleep for the night, right? We've all been in those scenarios where we're like, wow, this hospital is doing more, going above and beyond to care for the well-being of folks. But what are some of those ways that we can feel that in the environment? I asked a more pointed part of that question on my Instagram page about a year ago, about white supremacy specifically, and how white supremacy thinking and behavior, which I think Dr. Bridges, though she doesn't say it explicitly with that passage that she quotes, is getting at, how it feeds into and kind of shapes the system and structure of healthcare. And I was shocked. I was disheartened. I was kind of moved to some sort of action at the numerous responses. This is just a snapshot. I actually deleted the slide, by the way, because I was like, there's no way I can get to all the responses. And it shakes you, right? To the question of, in what ways does your hospital manifest white supremacy? People talked about treating the minimum according to insurance, very similar to what I was mentioning at Alpha Hospital. The drug services and drug testing being heavily targeted towards BIPOC, very similar to what Professor Roberts just mentioned, this hoarding of power, not seeing diversity in your staff members. There was someone messaged because the box that you have on Instagram was not big enough to get to their full point. The fact that your white attending bumps the scheduled C-section while who happens to speak Spanish for her private patient. And when she's called out, they say, does she even understand? Maybe it was a joke. Maybe she was trying to be funny, but doesn't that give a new feeling in the environment that not only is feeding into the disadvantage, but it continues to cycle through it, right? I shared these slides with Erin, and so hopefully if you don't get a chance to read all of these and let them just simmer and reflect on them and reflect on whether you yourself have heard of any of this stuff. You can read it through the PowerPoint slides, but I think what I'm trying to get at is that the abstract concepts of power and structure, which are the true root causes of bias, become very tangible differences in healthcare outcomes. And it's these very structures and factors that go hand in hand with the social determinants of health, right? As we all know through the World Health Organization, that's the environments that you're born, you live, you work, play, age, worship, all that. It goes hand in hand with the way that those social determinants are able to be experienced and how people of color especially are able to have good health overall in the first place. Good schools, good education, good jobs, good housing, living in non-violent communities, etc. This graph, this image, by the way, chart is adapted from Dr. Joy Perry, who's an OBGYN, another one of my very big crushes in medicine and academia. And I think it shows, and with the quote at the very top, that it's racism, not race, that causes health disparities, but not just so simple, it's so layered. And that we really have to reflect and think about, the faces of Miss Hazard, that it's not just one thing that caused her to unfortunately die and pass away that evening when she went to the hospital, right? So I kind of want to conclude with just open-ended questions. I'm not going to answer these. These are, I think when you have a case, especially in medicine, there's this feeling that you have to start the case and be like, this is what happened to me on the floor, and then end the case with like, and this is what I did, assessment and plan, and I'm done. Like, here are the answers. But I feel like for tonight's presentation, the didactics and with the multiple different perspectives and scenarios I've presented, there really aren't any conclusive answers, right? Aside from knowing that in order to solve the disparities we so often see in healthcare, we have to be aware of them. Number one, just like you are here tonight, staying late, at least for me late, but staying on here late to learn alongside us. And just as Professor Roberts closed in her own presentation, that we have to work hard at this societal commitment because it requires so many aspects to provide safe, accessible, reliable care, not just in medicine, but outside, equitable living, equitable education. Yes, the answer is yes, racism prematurely shortened Ms. Hazard's life, and it does for so many others. And it's the reason why we have disparities. Maybe her providers did too with their biases, but the onus is on all of us in this room to figure out how we can address social determinants of health. I love how Dr. Roberts, you said it at the end of your presentation, make this more equitable humanity so that we can improve as will result the healthcare system that is currently skewed against people of color. And so I hope that with this presentation, you take something away with you, and I look forward to reading some of the questions and answers in the chat.
Yeah, thank you so much, Dr. Barbell. That was actually man, the presentations this evening have been just a wealth of information, and I'm sure I speak for everyone when I say that it's been very informative and also just very insightful and enlightening. So I was going to try to summarize some of what you presented. However, like I said, there was such a wealth of information, and just also due to respect the time, especially for those on the East Coast like yourself, I do want to just kind of jump into a few questions that we weren't able to get to earlier, and hopefully while Dr. Roberts and yourself are both here, we can hopefully get some of your expert weigh in on the comments and questions that some folks had from earlier. So there was a particular question that came through that was shared directly or anonymously. So pretty much they're asking if either of you have guidance for navigating a role as a mandated reporter in light of the clear data that CPS is racist and harmful and punishes poverty. And is there a vision for how we can do better for the families in our care as healthcare workers?
So maybe I'm going to have to hop off soon, so I'm going to answer that question. I'd have an early morning meeting. But thanks for that question. So first, let me make a point about mandated reporting. It's very clear that healthcare providers don't really follow mandated reporting because we know that they do not report universally on wealthy white patients who use drugs while pregnant or whose children have problems that they're unable to handle, or where there's evidence of neglect. They don't feel they're mandated to report those patients. As I said before, there is clearly established, well-documented evidence that healthcare providers are far more likely to suspect, test, and report Black patients, especially in public hospitals, and especially as Dr. Bravell was saying, if they're on Medicaid, then reporting wealthy white patients who use drugs while pregnant. And so there really isn't mandated reporting. There's mandated reporting of impoverished and low-income patients who, especially if they're Black, Indigenous, or people of color. So, and especially if they're Black or Indigenous. So I just important to note that there isn't really mandated reporting in America. Now, there's also a move to end mandated reporting. In fact, in Philadelphia, after a set of hearings, our city council just issued a report maybe a couple weeks ago recommending that it be ended, at least in the city of Philadelphia. And there's legislation pending in New York State as well to end it. And some people might say, oh my goodness, well, that would leave children in danger. No, all that it does is give healthcare providers more discretion to be able to support instead of report families where children have needs. And as I mentioned before, most reporting has to do not with physical or sexual abuse, but with neglect, with the doctors or other healthcare professionals who see that children have unmet needs and believe that they need to report that to CPS. So I don't want to give any legal advice, even though I am a lawyer, and I need to know the context, but I think that healthcare professionals have much more discretion than they may acknowledge. They use it when it comes to wealthy people, patients, and they can use it when it comes to less, to needy patients as well. But the answer is to change the law and to support efforts to end mandated reporting. And you can look up articles about this. I'd recommend the work of Mikal Raz, I'll put it in the chat, who is a physician at University of Rochester who's been calling for ending this. And many, many people are recognizing that mandated reporting drives people away from healthcare and other supporters and does not do anything to protect children, because you're free. You're always free. If you think that a child is in danger, you're free to call CPS if you want. It's the mandated reporting that makes people believe they have to, instead of using their judgment and using the resources they have, turn families over to a system that's not going to provide for them. It doesn't have the resources to provide for them. It doesn't have housing to provide to a homeless family. It doesn't have health care to provide to a family that needs more health care. It just mandates that family caregivers participate in all sorts of tasks and that they have to get the resources, and if they can't, take their children away from them. So again, it's hard to answer, in specific contexts what to do, but those are some overall thoughts that I have about what to do.
I want to share in the chat. We actually have a participant who noted that there was another echo that they went to that shared that 50% of OCS and CPS reports result in worse conditions for children in their care. Yeah. And Mr. Gill, I see that you had come off of mute.
Yes, I support this idea. I'm a psych provider and also family nurse practitioner before. The people, doctors and primary care providers should have freedom to report whenever it is necessary, when they know that the situation will get better, maybe, then they should report. Otherwise, whatever care the person is getting or your child is getting, you actually take away that, because you put into a different environment totally. That will hurt actually more. I usually don't do that anyway. I mean, I don't want to admit that, but I only report when it's going to help the child or help anyone. If it's not, it's going to make the situation worse, I don't tend to report. Okay. In other words, I find my own solution for the particular person, to have a good contact and give counseling and the resources, find a solution. Whatever CPS is going to do that, I should be able to do it myself. And all the clinicians should be able to do that. And doctors can do that. And CPS is also the similar type of people are there. They're not different than you. They're the same. They're just in work with a different branch, and they just do the only the transaction that we shift the problem from here is a different problem. Now you shift to the CPS, it becomes actually a bigger problem. It's a different problem. Mm-hmm. So I think that should be at the discretion of healthcare providers who clinicians, supported, even clinical services department, they can do that, social services too. But the department of handling CPS investigation, that is not that much needed most of the time, because the child gets condition get worse. I don't support that idea that everybody needs to be reported if they notice something, because 95%, 93% of the people, anyway, they kind of lie, the way through. When they come to you, they're frustrated, they don't know, especially people who take part, they can't even express anything because their expression system is gone. They don't know what they're telling you. So you have to be very clear and telling the truth first before you even thinking about reporting. And many times we are even unable to get the truth from the people because everybody is trying to survive. They lose benefits. Actually, disability system itself, like some people say, disability people keep the person disabled, because of the financial issues. Many people don't want to be on disability because they are on it because they lose disability benefit, and then disability actually don't let you heal. The system is actually more complicated than we are dealing with. Many people have told that that's good, but we need to do studies, like for example, GFR studies. We need to have studies done without paying attention to that. So that's further study needs to be done to undo that. For all
Mr. Gill, I'm so sorry for the interruption, but I just want to say thank you for your thoughts and just share that they're echoed in the conversation as well. Many folks have mentioned the fear of reporting really hindering access to healthcare and some other notes. Folks, we've had an incredible presentation by Professor Roberts and by Dr. Burvell as well, a series of presentations. We've gone on longer than we typically do, and with respect to everybody's time, we are going to move into closing. But I just want to express my deep thanks and appreciation to both Professor Roberts and Dr. Burvell for providing us with such an education and an opportunity for discussion. The engagement in the chat makes it clear that there is a hunger and desire for engagement with these topics here. So we really appreciate your contributions to developing that in our communities. Participants, thank you again for joining us today. I want to offer a few reminders. Our next session will be Thursday, June 9th, and we'll be discussing building health equity and envisioning a culture of change. And in particular, we will be focusing on stories of systems change and frameworks for applying successful best practices to create health equity. Dr. Kyle T. Mays, an Afro-Indigenous, Saginaw Chippewa writer and scholar of U.S. history, urban studies, race relations, and contemporary popular culture, will be our didactic presenter. And we'll also have case presentations by Naomi Ninkisi, who's a UW MPH student. And, actually we brought this, I believe a participant brought up the use of EGFR, and I believe Dorothy Roberts and Dr. Burvell did too. Naomi actually, her advocacy led to it being discontinued in the UW medical system. So I look forward to additional conversations around that topic next presentation. And we'll also hear from South Central Foundation's representatives from South Central Foundation's NUCA system of care, who'll be sharing some of the changes that they've made on an institutional level to advance health equity. Again, thank you so much for your participation today. Please check out links in the chat for our survey, as well as how to access additional resources from this session. And Hub team, if you have a handful of minutes, we're just going to do a very, very quick debrief. Have a great evening, folks. Take care.